Fortunate today to have at least two special guest stars, one of which is Joel Gallant, who many of you may have seen and have waved, and I hope he will start a new wave of people turning on cameras during meetings. Welcome back, Dr. Gallant, and hopefully we'll be here for case discussions and other things in the future. Awesome. And then also for our speaker today, we are very fortunate to have Dr. Greg Kirk. So I think everyone knows Dr. Kirk. And if you don't, he is, I think, the Vice Dean for Research at Bloomberg. Is that right? But also has been instrumental in the work of the ALIVE cohort for many, many years here at Johns Hopkins, has done work across the spectrum of people living with HIV, both domestically and internationally, with focus on lung disease, on injection drug use, on aging and frailty. And we are so fortunate to have him here today to talk to us about HIV and aging.
Great. Thanks so much, Eileen. Good to see Joel and other faces. However, I'm going to actually go dark, and that's because I bought a new computer and my monitor is not as nearly as high a quality. And after about 10 minutes, I start pixelating. So I don't want to give anyone seizures. It's hard to turn that off. So my apologies, but I'm actually going to go dark as I start to share my screen. Yes, I do certainly want to thank the organizers and you guys. I got the dual screens. You guys see the full slides, right?
Yep, it looks perfect. Thank you.
Perfect. Great. So thanks again for the opportunity. This is not a clinically, there are no cases involved here. I thought about making some, but I didn't have time. Sorry about that. But this is really intended to update many of you who are familiar with ALIVE and reintroduce ALIVE to many of you. It's very much focused on the aging people who inject drugs in Baltimore. So this is pretty rather focused on that group of individuals, as well as really leveraging the data from, now we're on year 37 of ALIVE, and it really reflects the long-standing work of many, many individuals. And thanks for I'm very privileged to have the opportunity to help shepherd this study forward towards the fourth decade, but it's really on the shoulders of many other individuals. So I guess I'm going to have to click. So what I'd like to do this afternoon, is talk about HIV and drug use in Baltimore very briefly, and really talk about both the biology and behavior and how those interact in people living with HIV confronted with substance use. And I'm going to use two illustrative examples, all nested within ALIVE, and that's going to focus on, from the organ system approach, to emphasize lung disease. And amongst the age-associated geriatric phenotypes, we're going to talk about frailty. And I do want to, at the end, share some information about how to partner with ALIVE. There's, I don't know how many people are on the call, but please yell out. I won't see any hands or anything. Please just yell out if you have questions, comments. I'd love to use this as a bi-directional discussion. I'd like to share with you what ALIVE is doing, but I'd also welcome your thoughts on what we should be doing. We are now entering, again, as I mentioned, towards our 40th decade. We just put in the ALIVE renewal. There's a lot of things that we're proposing that are new and innovative. There's a lot more community engagement with a national advisory board, as well as partnerships with Maryland and Baltimore, even more so than what we've done before. A community advisory board, as well as a participant advisory board. So feel free to interrupt as we go along. I don't need to highlight to this audience about the history of Baltimore, originally viewed as the heroin capital of the world. And for many decades, injection drug use accounted for a much higher proportion of those living with HIV compared to other regions in the US. We also know, as this data illustrates, the recent uptick in overdose mortality related to synthetic opioids, fentanyl, and the opioid epidemic. Alive has been around throughout this period to help characterize this. I think this is one of the good news slides, and this is state data, but of course, we know that much of the HIV diagnoses in Maryland are driven by what happens in Baltimore. And you can see in the red line here, the notable decline, Alive started in 1988. So during this uptick in the red line of the proportion of new diagnoses related to injection drug use, and you see the decline. Our data mirror this, and I'll show that in a little bit later. So you can see that whether it's the new numbers or the proportion, injection drug use has been very important, but it's not, but the numbers of new diagnoses has dramatically declined. This is sort of the timeline, again, starting out with Frank Polk, who initiated the Alive cohort back in 1986, along with shortly thereafter, Ken Nelson, starting the HIV negative comparison group. Really, this was early on. We wanted to know what are the risks related to injecting drugs. What are the factors that might influence? I think I see Homie on, I don't know if Tom Quinn is on, others like, this is like many of the early studies before HIV RNA viral load measurement was really operationalized. So some of the early data to show the risk associated with CD4 and viral load were nested within Alive. Since about 2005, Shruti and I have been the co-PIs. And this sort of highlights what's been happening in terms of recruitment. We now are around 6,000 participants have been recruited. There's been substantial mortality over these decades, and we're currently in open enrollment now. So at the end, I'll highlight how you might want to refer participants, and we'll be trying to enhance our recruitment from the HIV clinic as well. So we've had about 300 new enrollees. These have really been 3 successive waves. The first initial wave with about 3,000 recruited, some smattering of recruitments in the 1990s. In 2005, we recruited another 1,000. In 2015, another 800. And our goal is to recruit another 1,000 or more with this current enrollment. It was in 2005 where we really changed the directionality to focus on aging-related outcomes. And for many of you on the call, you may remember how aging in HIV was a novel topic back then, and there was a lot of reticence. There was a lot of hesitation, like, why are we worried about aging in the context of HIV? So we've come a long ways. It's no longer novel. It's very much integrated into the understanding and clinical management of HIV today. But it wasn't back in 2005. Alive is a classic observational cohort. We don't recruit from care settings, be that HIV care or substance use care. We typically recruit from word of mouth. We have a mobile van that goes out and targets areas where people who inject drugs may be, whether that's in services or other locations. The important factor that has helped Alive contribute to understanding what are the impacts of HIV is that we recruit people both with and without HIV. About a third of participants historically have been those who inject drugs and have HIV, and the other 2/3 are people living without HIV. And with that epidemiological appropriate comparison group, we've been able to directly evaluate without while adjusting and accounting for the particular risk behaviors of people who inject drugs, and look directly at what might be attributable to HIV itself. It's an adult-focused study. We do every 6-month follow-up. We're located on McElderry Street, about 3 or 4 blocks from our East Baltimore campus, just behind and a half a block over from the Northeast Market. We collect a lot of data in Alive. So we have we now have participants who've contributed 76-month study visits. So that's a lot of engagement over the years. It's really grown from a partnership with our participants in the community with a very dedicated and engaged staff. And we have been able to have them spend half a day with us where we ask lots of questions about drug use, about support, about their behaviors, about their clinical experience, a lot of standardized assessments. We also have routinely done testing. We do annual testing for chronic diseases. We, of course, do CD4 and HIV viral load testing. We do periodic testing to fully characterize viral hepatitis. For a long time, we've been doing a geriatric assessment that includes the phenotypes for frailty and physical performance. We are going to discuss a lot of our lung function data. We're part of an initial FDA registration trial for evaluation of FibroScan. So that's been within Alive for a long time. We routinely link to CRISP, including both the clinical and billing data, to the National Death Index, as well as to the cancer registries. We have sub-studies looking more intensely at some of the social and behavioral data, including some qualitative assessments, as well as an intensive mHealth focused study where we follow individuals for a week or two with a smartphone asking questions in real time. And this just sort of illustrates some of the more intensive data collection. We do urine toxicology on this, as well as enriching for biological samples. HOMI helps us coordinate our biorepository, which is now approaching 1 million unique aliquots. We've got a lot of follow-up. We historically have had about 90 to 95% follow-up of people who come back at least once. That's dropped in recent years, and I think I can share some data about why that might have happened. We had a lot of HIV seroconversions in the earlier part of the study, and as mentioned, more than 1/3 of individuals that have been recruited in the study at some point in time have actually passed away. These are the subsequent recruitment cohorts, and you can see that this really reflects what's going on in the injection drug use epidemic in Baltimore City. The age has gone up with successive recruitments over calendar time. The proportion of African American has actually declined. The proportion that is male was much higher in the very earlier years compared to more recent years. There's a trend towards not just being in Baltimore City, but an increased representation of people from Baltimore County and adjacent areas. Despite the more recent recruitments, we still are tapping into people with long careers in terms of injecting. And I want to highlight this 7%. I was wondering whether, there's been a consistent 25 to 30% historically. It was down to 1 in 4, 1 in 5 with more recent recruitments. We've extended this now to up to 300 new participants in the past year, and our traditional approaches for recruitment have really not tapped into people who are HIV positive and actively injecting. We've changed some of our recruitment criteria and will be hopefully increasing those numbers. But that's a good news story as well. You can actively inject drugs in Baltimore City in present day, and your risk for acquiring HIV is much, much lower than it was historically. I just put unstably housed to highlight for my own recollection, we have about 50% of our new recruits that report being unstably housed in the last 6 months. We know that nationally, homelessness has been on the increase. In the early years, we had about 20 to 25% of people that would report being unstably housed. I would not have expected that in 2024, we would be having nearly twice the prevalence of participants reporting being homeless or unstably housed in recent months. Alive was originally developed to look at what's happening with this new HIV epidemic, what's the risk associated with HIV. Obviously, there's been a major focus on the natural history of both substance use as well as hepatitis C. It was used as a validation to evaluate syringe exchange programs, test and treat initiatives. In 2005, we transitioned towards the treated history. What are the barriers to getting persons who inject drugs through the care continuum? And really what I want to focus on is number 6, the natural and treated history of co-infections and comorbidities and aging phenotypes. Some big picture findings that were presented at CROI this year. You can see as the over calendar time, the proportion of alive participants that are using ART has notably gone up. We documented for decades before this how new therapies were delayed about 3 to 4 years in our participants compared to other HIV risk groups. And we consistently, and even at present, we still have a fair proportion. This is 36% in 2019. If you extend this data to more recently, we have a much lower proportion that are viremic. It's down now into the teens. We're approaching getting at least to the 90, maybe not the 95th target for viral suppression among those who are in the or active participants. But that's pretty dramatic. What we now observe is that the duration is probably different from what you see in the HIV clinic, where all of your participants have been undetectable for months to years to decades now. We still have issues with durable viral suppression, such that even amongst our participants who've gone a couple of years of being virally suppressed, we still see a fair number with breakthrough. These aren't really blips at low levels. These are people who relapse to drug use and interrupt their ART and actually have viral suppression for a period of time. We have good news to report that we have notably shown an increase in the uptake of direct-acting antivirals for hepatitis C, the proportion that are viremic. We've also demonstrated with Javier Cepeda's work that this has improved liver-related outcomes, including mortality with the uptake of hepatitis C therapy. This, again, in the blue line, illustrates the good news in terms of HIV incidence. We have very few seroconverters amongst our HIV negatives routinely followed. The concern is that while harm reduction approaches have really dramatically reduced the risk for HIV, we see an increased risk in recent years related to hepatitis C. So we're not done with harm reduction efforts, particularly for hepatitis C infection. We've documented, as is well described in many different settings, the increase in both fatal as well as fatal overdose amongst the cohort. And here's a decades-long look at mortality patterns. Here you have in panel A the improvements in CD4 counts over time with a notable decline in HIV and infectious disease-related mortality. We have the decline in drug and violent-related deaths with an uptick more recently, notably related to the opioid epidemic. And here you see with increasing age, we have an increase in age-related causes of death. And that's what I want to focus on in the next few minutes. There was an Office of AIDS Research HIV and Aging working group a few years that really wanted to look at what are the underlying mechanisms of aging with HIV. And those include sort of direct effects of the meds themselves, the reservoir, co-infections. We've heard a lot about the microbiome, as well as behavioral issues, as well, and the targeted mechanisms ranging from mitochondrial damage to epigenetics. Within Alive, we've tried to be systematic about this approach, and we currently have ongoing or have had studies that have really looked at many of these different mechanisms. I don't think we can check the box on stem cell exhaustion, but in the others, we've had largely independently funded studies to look at these. This obviously is beyond the scope I'm not going to be able to delve in. We could have a whole talk on mitochondrial damage or epigenetics. So I'm not going to be able to summarize all of that data in the next few minutes, but I would like to give you some big picture viewpoints from some of this work. Within the NE Accord, the IDU, or PWID as we now term it, risk group from a few years ago was still about 20 years lower life expectancy compared to men who have sex with men. In more recent data, this is really from the UK and ART-CC cohorts, you can see that people who inject drugs still have notably lower life expectancies. And this doesn't change dramatically whether you were infected earlier or later. It's a little bit better, but you still can see notable differences among people who inject drugs. So there's still a survival disparity. This is really due to comorbid diseases. Some of these are facilitated by lifestyle-related factors, and some of them are facilitated by biological factors, including poor virologic control. These individual comorbid diseases lead to aging, and in particular, aging-related syndromes, often operationalized as frailty, physical performance impairment, as well as other multimorbidity and other phenotypes. Today, I'm only going to highlight one illustrative organ system that's focusing on lung disease, and then from a geriatric phenotype perspective, focus on frailty. In 2000, even before 2008, we started to do respiratory questionnaires as well as do spirometry within the Alive Clinic. And we have had NHLBI support since around 2008. So we have amongst the largest and longest running cohorts of people with and without HIV with sort of detailed spirometry and respiratory questionnaire data. We were amongst the first to really document controlling for smoking that HIV is associated with an increased risk for lung cancer. And the concern was that there was clearly a large effect of people with HIV having higher lung cancer rates and COPD rates, but there wasn't good data in many of those settings to control for individual smoking behavior. As you might expect, people who were in Alive had about an 85% current smoking prevalence, and that's much higher than pretty much any other HIV cohort, and it's certainly notably higher than the general population. And the suggestion was that it's all about HIV. We looked and compared once again the HIV positive to negative comparison group, and you can see that pretty much any way you slice smoking behavior, it really wasn't different by HIV status. We wanted to look at longitudinal lung function trajectories, adjusting for things that would influence lung function decline. And you can see that here's for a typical representative participant, the annual decline was about 24 milliliters per year of FEV1. So this is looking at absolute FEV1 within an initial 3-year period. We've extended this work. This is work led by Brad Drummond many years ago. We note that the HIV positives were notably lower at baseline, so their FEV1 absolute value was lower, but the rate of decline was only slightly lower. It was really within this subset that had higher HIV RNA measurements that had the more dramatic decline in lung function. And this is a recurring theme that we will revisit many times in live data. And there's both biological and behavioral reasons for why there's greater lung function decline related to persistent HIV viremia. We also wanted to look at DLCO, the phenotype of respiratory disease associated with HIV involves impairment of diffusing capacity, and we see that HIV and COPD have an additive effect on the risk of DLC impairment. We, of course, acute exacerbations predict are associated with lung function decline and contribute to that lung function decline. And in work from another pulmonary fellow transitioning to faculty, we demonstrated a couple of fold higher risk for acute exacerbations of COPD associated with HIV infection, adjusting for other things that would impact that risk. HIV, we also looked at both quality of life measures as well as healthcare utilization. Consistently, we found that those with the poorest virologic control had greater degrees. This is the outcome here is reduced physical function score from the MOS quality of life measure. So you had worse quality of life if you had lower FEV1 % predicted, or if you met the COPD airflow obstruction definition. And there's an interaction between the viral load and the FEV1 measures. You're also more likely to get to either be seen in the emergency room or be admitted if you had poor virologic control and had a decline in your FEV1. So again, virologic control being very important, irrespective of whether those measures are absolute FEV1 decline, diffusion impairment, acute exacerbations, and quality of life or healthcare utilization. So after exploring the impact of viral load, we also wanted to look at what we recognize household air pollution as being very critical to respiratory health. And we were hypothesizing that HIV may modify the effect of pollutants on respiratory outcomes. So with colleagues from environmental health and pulmonary, we performed an analysis. This is part of the SHIELD study, so actually includes not just live participants, but also a substantial number of Hopkins HIV clinic patients who underwent spirometry and a respiratory questionnaire. You can see about 1,000 persons with HIV and about almost 900 HIV uninfected persons. Most of them were virally suppressed, but not overwhelming proportions. Only a minority had a low CD4 count at the time of measurement. We looked at what types of cook stoves they were using, exposure to household allergens, as well as occupational histories. And we then looked at a standard American Thoracic Society assessment for characterizing respiratory symptoms, including phlegm, wheeze, and cough. And consistently, we saw that those individuals in the circles here were about 1.5 times more likely to have symptoms associated with exposure to secondhand smoke or to NO2 if they were HIV infected. this led us to do a pilot study. So we went out, took these little trash cans full of monitors to monitor a variety of different both PM 2.5, nicotine, NO2, as well as collecting some other data. And here from that pilot of 36 households where we would do monitoring in their household for a 1-week period, you see that first, the red line is what would be expected levels of PM 2.5, the most important particulate in terms of respiratory health. And generally, the EPA limit is quite, we find whether you're in a smoking household or a non-smoking household, the levels are above the recommended limit, and we see an increase in those with HIV infection. So this led to Shield Air, a detailed study where we're now up to approaching a couple of hundred with monitoring for a week or two. We do these 6 months apart to look at seasonal effects, and we're looking at a variety of biological responses. We also look at detailed outdoor air pollution exposure measurements as well. So that work is ongoing. We've done, nested within this study, we've done bronchoscopies and demonstrated an immune-mediated reduction in CD4 counts in the lung compartment compared to the periphery. And additionally, work led by Sarath Raju in pulmonary, which is ongoing, but this is some early work showing there's a different phenotype in those with HIV and COPD compared to those with COPD without HIV infection. And in particular, this is looking at a way to characterize using CT to visualize the small airways of the lung. This is called parametric response mapping. Without going into those details, the yellow illustrates small airways disease. And you can see on the right, in the illustrative example with HIV, there's a lot more small airways disease in the setting of HIV. And when you quantify this in the formal analysis, it is statistically significant and notable, about a 2.5-fold higher risk for small airways dysfunction. So this work has, this epidemiological work has led to a bronchoscopy-focused study with an immune-mediated hypothesis, as well as a different view towards a different clinical phenotype associated with HIV and lung disease. Any questions about the HIV and lung disease data before I transition over to frailty?
Dr. Kirk, it's Eileen. Just really quickly, do you think that, like, when you think about from a patient perspective, would this be something you would want to include in counseling about, like, other risk factors that can be reduced in terms of lung disease prevention, or how do you think about it in that way?
Well, first, I think we have to be much more aggressive in referring people to undergo pulmonary function testing. The guidelines, and actually, some of you may remember when we did a pilot study of who meets criteria for referral for pulmonary function testing. Really, if you're an adult and you've ever smoked and if you had any symptom at all, then you should, the national guidelines, even for non-HIV infected persons, would be to refer them for pulmonary function testing. Within the Bartlett Clinic, there's a very high proportion that were recommended. We instituted within the cohort referrals, an automated referral that said, would you like to recommend this person for PFT testing? And there was a big drop off. Clinicians didn't actually necessarily follow up on it to a great degree. So I think the first thing is to stage the disease in terms of pulmonary function testing. I'm actually really, for the first decade of Shield, we really didn't see people who who were stopping smoking. But as people have aged into now, the median age and alive is high 50s and into the 60s, we're actually seeing a much higher proportion of people who are able to stop smoking. We did a randomized trial to look at telling people their lung age. And basically, you take their lung function measurements and say, well, you're 45 years old, but you have the lungs of a 65-year-old. And we compared that to contingency management, where we were incentivizing people, financially incentivizing people to come in with negative carbon monoxide measurements that could go up. And as has been seen in other populations, contingency management does help move people towards smoking cessation. The lung age didn't. So I think that we have to, so Eileen, I think in response to your question, clinicians need to be aware of lung disease as an important comorbidity and act appropriately. And I think at the same time, when we think about contingency management and other approaches for substance use in other settings, sometimes those approaches ignore smoking. I don't care if you're smoking as long as you stop injecting. In many cases, I think these go together, and there may be inflection points in people's lives where, at the same time that you're getting off injecting drugs, maybe that's an opportune time to actually try to stop smoking as well. It doesn't work for everyone, but I think we have to keep it in mind to a greater extent. Any other questions? All right, let's talk about frailty. And I think I saw Damani. Is Damani on? I can't see. Damani, are you on?
I am.
Okay. A lot of this work flows from the initial fellows work into junior faculty work led by Damani. And I think you might have seen some of these slides. Frailty is a syndrome that you know it when you see it. It really is reflecting a lack of resilience to stressors, a decline in your physiologic reserve, and it's associated with a lot of adverse health outcomes. And it was operationalized by Linda Fried here at Hopkins many decades ago with the 5 parameters. If you have 3 or more of these parameters, it's considered meeting the Fried frailty phenotype. So Damani and I started working in Alive to assess frailty back in 2005. So again, we've been doing this a long time. We initially demonstrated HIV, you're much more likely to be frail. Frailty, there was a lot of hesitation amongst a mean age of 45 years old. The geriatric researchers and clinicians were like, why are you even looking at frailty in 40-year-old individuals? It is a dynamic state, but whether you look at this at a single time point or a consistent time point, there are substantive associations of frailty with hospitalization from a variety of different causes, both chronic and infectious related hospitalization, as well as mortality. If you're HIV positive and meet the frailty phenotype, you're 7 times more likely to die. Again, there's both biology and behavioral contributions to this. Obviously, chronic inflammation is an important outcome of aging with HIV infection. Using a standardized inflammatory index score that's been operationalized in geriatric cohorts, non-HIV general population geriatric cohorts, we demonstrated inflammation was independently that it's independently associated with frailty as well. And there's so the biological explanation in the general population of inflammation associated with frailty is certainly replicated within the HIV infected population. Even accounting for that biological perspective, there's neighborhood influences on frailty. We know that the dramatic 1 mile difference associated with dramatic differences in survival here in Baltimore. We know that neighborhood factors are associated with many different outcomes. And here we have Damani's work looking at neighborhood deprivation, inflammation, and frailty. And I'm not going to go into how you measure neighborhood deprivation, but basically even controlling for a lot of other factors that are associated with frailty, we see independent associations of those with living in the highest deprived neighborhoods associated with frailty. We, of course, are extending this work to look at other neighborhood factors. For example, like right now, we actually have 1.5 million Google Street View images where we use AI to quantify the physical disorder. You can look at broken windows and lack of green space and disarray in the neighborhood. That neighborhood physical disorder has been associated with many things in Baltimore as well as in other cities. So we want to extend this and combine both the biological and behavioral approaches to look at what's important in relation to frailty, as well as in relation to the adverse outcomes associated with frailty. So just to recap, HIV increases the burden of frailty. We've documented that increases both hospitalization and mortality. Inflammation and neighborhood environment are key mediators of this within our population. So again, I highlighted lung disease and frailty, but we've done other work in other settings. And I think the recurring theme that with liver fibrosis, HIV is associated with about a 10-year age acceleration in the degree of liver stiffness. With colleagues in cardiology, we've demonstrated that HIV increases cardiac fibrosis through cardiac MRI studies. Hypertension is fascinating. We find that those with viral suppression are much less likely to have hypertension. First, hypertension is very common. By the end of follow-up, we're about 75% of our participants will have been diagnosed with hypertension. Again, this is into the age 60. When you look at those that are free of hypertension at baseline, so while you have a protective effect, if you're able to get virally suppressed by going to the HIV clinic and getting on ART, you're actually able to manage your hypertension much better. Not surprisingly, if you can take your ART, you can probably take your hypertensive meds. Whereas we see the reverse effect of a biological association of HIV viremia associated with incident hypertension. We've looked at a variety of other outcomes: diabetes, proteinuria, cancer. We have an oral health study in collaboration with the University of Maryland. The level of periodontal disease, we know that, I'm sure many of you recognize from your clinic patients that health complaints, wanting to see a dentist is a recurring and frequent complaint. The level of periodontal disease is probably not as high as we'd expected, and in many cases, that's because the number of existing teeth in many populations is so low. So it actually turns out that many are edentulous, and the risk for periodontal disease therefore is notably lower. We're following that up by looking at the microbiome and how the periodontal disease microbiome may contribute to the other NCDs. We're looking at neurocognitive function in relation to tibial bone lead levels currently. As you might expect, bone lead from our initial pilot is probably 2 to 3 times what would be expected of similar aged participants in the US. So we're very interested in looking at our novel we basically have a barcode scanner that can rapidly assess bone lead levels, and look at that in relation to both neurocognitive function as well as standardized assessment of hearing, vision, smell. We've done a lot of work with frailty, which I presented. We've done similar analyses and find similar findings, whether that's related to multimorbidity or to a standardized short physical performance battery. And I think that we can think about whether gait speed, grip strength, or some of these other measures might be operationalizable into clinical settings. We have a very strong component now amongst our aging cohort that looks at social isolation. We're going into people's homes and putting in monitors to look at activity levels, sensors on refrigerators and cabinets, looking to see whether we can remotely sense frailty and changes in activity levels amongst individuals in their own household. So interesting, again, we're trying to balance both the biology and the behavior in our studies. I wanted to emphasize again this recurring theme of age-associated outcomes with poor virologic control. This is looking at whether it's CD4 or viral load, looking at mitochondrial function. So Jing Sun has led this work within Alive, and you can see that compared to HIV negatives, those with lower CD4 counts or higher viral load levels consistently have poor mitochondrial function. This is in measurements of mitochondrial DNA copy number. Again, this is viewed as a common pathway for age-associated diseases. It's been associated with all the chronic diseases that I've mentioned. And what you find is again, these findings. Another sort of common biological pathway in terms of aging is epigenetic age. There's now 8 different epigenetic age clocks, and we've looked at all of them. But you again see consistent findings that those who are HIV negative in the blue line tend to, compared to them, their epigenetic age was actually pretty consistent over time. Whereas in the purple line, you see the acceleration in follow-up over a 5-year period in terms of estimates of epigenetic age up to about, again, this 10-year age difference. Whereas those who are virologically suppressed, you see a mild improvement of perhaps a couple of years after being undetectable for a period of time. So I know it's not revolutionary. We know that suppressing the virus is key to improving outcomes, but I think it's pretty resounding to see such consistent findings across the spectrum, to see the associations with viral load repeatedly, to see this 10-year age acceleration being repeatedly visited, whether it's lung disease, liver disease, or other things. So just to recap, whether it's sort of the ultimate integration of biology and behavior is with Bob Silicano. We looked at the viral reservoir, and it's really about these treatment interruptions that's associated with higher viral reservoirs. Again, it's not surprising, but it was really, there's this hypothesis that it's about the specific drugs used, but it's much more not the specific drugs used, but whether you've had a recent interruption in your ART to the neighborhood. And again, we're doing a variety of studies in using the mobile van, doing home visits, doing smartphone-based studies to look at patterns of drug use in relation to the appropriate management of chronic diseases, as well as to remote sensing of frailty. I do want to highlight that particularly within this sub-cohort that's more intensively followed, I don't know that for years we've said that we don't have meth in our population. And if you can figure out this sort of wheel diagram, these are individuals, this is sort of the urine drug testing, and you can see heroin is, although participants report taking heroin, they actually, only a very small minority actually are taking heroin. So the confirms the replacement with synthetic opioids. But most people are polysubstance users, and you can see cocaine and fentanyl being the majority of a notable representation of xylazine, and something that is not self-reported by the participants. They don't report that they're taking methamphetamine, but we are now detecting it in Baltimore. And I think if I would throw out a warning, maybe this is low-level adulterants, but maybe this also represents a change in the patterns of drug use that we look at over time. So I'm going to end with just letting you know that we welcome collaborations. We've now got 600 peer-reviewed publications, funding from many institutes. We've had a lot of doctoral masters, postdocs, as well as early stage faculty that have gone on from working in Alive to various different roles. In the last funding cycle of 5 years, we had 34 R-type grants, 9K awards, lots of pilot awards. If you're looking for a CFAR pilot, it's a pretty good target population. I'm going to end by missing many people who I should thank. I recognize when you have 35 years of collaboration and contributions, I'm sure I'm going to miss lots of people, but I certainly want to thank the participants. Whether it's one study visit or 70, they've engaged with us and contributed substantially to this body of work. Our longstanding engaged Alive staff that really made this possible. Jackie, Tanita, and Eileen have been real leaders for many years within the clinic setting. I must say it's been now 20 years of Shruti and I partnering to co-lead Alive, and it's been a wonderful partnership. And we're hoping to get results of the new renewal in the coming weeks. So hopefully that will be continuing to support the parent award. There's a long list of Alive investigators. I've highlighted the work by Damani, Jing, and Sarah today, but there are many, many others who've contributed, some recently and some from the very beginning of the cohort. I want to leave this up for a minute. If you have participants who've actively injected drugs in the last decade or so, they don't have to be actively injecting currently. Please refer them. We're in open enrollment. Here's some QR codes, and feel free to, I'm happy to share the slides, and please refer them on. We'd be happy to evaluate and potentially include them in this body of research. And I want to also provide the link if you have an idea for a study, to introduce a new survey, to leverage our biorepository for a novel biomarker, or to look at the existing data. We would welcome your engagement and participation. And with that, I'm happy to turn we have just a couple of minutes. I see, is there anything in the chat? Social isolation. Yes.
Yeah.
Any other questions? I know it's been, this is not your typical Friday conference, but I do, and it was a bit, I almost feel like a candidate here in the last weeks of the election, making my case for Alive, but we really do welcome your collaboration. We have opportunities for engagement in many different ways. And while we're doing many different things, we welcome new ideas. And if you think, we're very receptive and open to your suggestions. Dorcas, did you have a comment?
Yes, Greg, no. Well, first of all, I just want to say thank you so much. I was not going to miss your talk. I'm so glad that you're integrating those aging assessments right into the practice, and you've been doing it a long time. I attended the international workshop on aging last week in DC, but my only question was when you talked about the frailty Are you also seeing pre-frailty, and what can we do to slow down the process of individuals, whether they're HIV negative, HIV positive, especially the HIV positive in your group, so that they don't have to get frail so fast? What can we do along the
Absolutely,
line?
Dorcas.
Mhm.
That's really critical. And pre-frailty is a big group. So the ones that score 0 points in Alive are the minority. Pre-frailty in different time frames and age groups is approaching 2/3 of the population. So as you can imagine, that's the bulk of people, and that is where we should be targeting potential interventions. You know, Damani's looked at an exercise intervention. Um, you know, I think in this younger population, we also don't want to consider frailty as irreversible. Frailty in our 50-year-olds may not be the same as frailty in our 80-year-olds or older. And I think pre-frailty should be the target for sort of preventive intervention. But I also wonder if we shouldn't also consider frailty the irreversible state and abandon the hopes for be that pharmacologic exercise or other interventions. I would refer you on to Damani. He's much more engaged in sort of the specific interventions that are appropriate. Unfortunately, maybe GLP-1 inhibitors will solve it. But that's not a feasible intervention. But kidding aside, exercise really is the thing that we need to do, but we know how difficult that is. That's not easy. Other
Exactly.
question.
And one last statement, using the 5 M's, but plus a 6M for geriatrics, modifiable, like you've been doing the work on smoking cessation and all of that. So excellent. Thank you so much. I'll talk to you later.
Thanks, Dorcas.
Greg, one quick question, because I know we're getting over time. It was a great presentation. Thanks so much. And I wanted to go back on your urine screens. And I want to make sure I understood this. So our patients are reporting use of maybe fentanyl and cocaine, but there is a lot of meth being used. And what you're saying is the participants are unaware that there's meth in. It's fascinating, right? That's why
Absolutely.
we ask them, are you meth?
Jeannie, it's exactly, there's discordance.
Yeah.
So actually, historically, most of them have come in and said, I'm taking heroin.
Yeah.
When there's no detection of heroin, it's all synthetic opioids.
Yeah.
In recent years, we've seen people, we've asked about methamphetamine for decades, and no one ever says yes.
Right. They
continue to say no, yet we are detecting it in the urines.
Yeah.
Same thing with, like, I'm not over, I'm unclear how much xylazine contributes to wounds. I know, like, it's I want better data about xylazine in wounds because again, we detect it. I see a lot of people with wounds who I don't think are on xylazine. So like, I know there's some good studies ongoing, and maybe they can be more definitive about what is the role of xylazine in wounds. I think we're in a similar approach with the really, fentanyl is kind of last year's synthetic opioids, and the nitazines and the even more potent synthetic opioids, I think. I just saw someone at Bayview with, who gets his, synthetic nitazine derivatives directly shipped from China from ordering online. And he was in the hospital because he's injecting into his femoral vein because he had sclerosed his other vein. So he's an active injector for 10, 15 years, started using these more potent synthetic opioids beyond fentanyl, and had sclerosis within a few months of starting to do that. So like, and then they have to revert to other potential injection sites. So I think the impact of those are really important. And then meth, like, we know meth is disruptive.
Right.
And that would be historically, it was about you add cocaine to your heroin, and then you have a more chaotic phenotype that's associated with many adverse outcomes. It's unclear to us yet how much methamphetamine may contribute. We're actually changing what we're doing. So now we're going to test everyone with urine. This data that I presented was really that small subset that we follow with smartphones for a week, but we're going to expand that to everyone to try to get a better handle on what's going on with the introduction of meth.
Thanks so much.
Okay.
Well, thank you so much, Dr. Kirk, for this really fantastic presentation. Just a real quick, if you could send us those last few slides, we'll put them on the Teams channel so that
Sure,
if
that
people
would be
want to
great.
access them for the codes or the emails, that way we can make sure people get that if they didn't catch it at the end.
Okay, sounds
And
great.
Thank
Thanks
you
very
so
much.
much
Have a
for
good
joining
afternoon.
us. Have a great weekend, everyone.